So good afternoon, everyone. Our topic is Mission Lifeline, STEMI and STEMI app. So Mission Lifeline, what is Mission Lifeline? This is an AHA national initiative to advance the system of care for patients with acute, high-risk, time-sensitive life and or quality of life-threatening disease conditions such as STEMI, NSTEMI, stroke, and out-of-hospital cardiac arrest. At Mount Sinai Hospital, our goal is to bring all the key stakeholders together in a collaborative manner to reduce morbidity and mortality while reducing all the complications and improving the quality of care and improving patient outcomes. So in AHA, we're focusing on STEMI today. With AHA, the recommendation is to reopen the coronary artery within 90 minutes. So for Mission Lifeline, we have this STEMI recognition. So before I start with breaking down the details on the STEMI recognition, I want everybody to just be familiar with how we do our work every day, and we take pride as a team in handling STEMI cases. So whenever you hear of STEMI, there are different pathways that you have to remember, just 3. So I want you to go home today remembering 3 pathways. We receive our patients through 3 different routes. First, you will hear FMC, first medical contact. What does it mean? It means these are the patients who have emergency, let's say from Times Square, from Central Park, from home, they dial 911. So what does it mean? So that's the category of the first medical contact to device. So within 90 minutes, that's the guideline of American Heart Association, we need to open the blocked artery. So when does the time start ticking? It's when they call the 911, the paramedic arrives, the moment they touch the patient, the time starts ticking. And within 90 minutes, the cath lab should be able to do the procedure, wire the artery, and balloon and restore the coronary flow. So imagine that multiple stakeholders, different personnel, different departments, they have to work together to make that happen. Why is it important? Because evidence-based, we have proven that there's really best patient outcomes if we follow that. The next pathway is the walk-in. So when you are a PCI-capable hospital, patient comes into the emergency department, the RN triages the patient, the time starts ticking. Again, they activate the cath lab. Within 90 minutes, the coronary artery has to be reopened. That's the next pathway. So they always think, oh, that's the fastest way. Kinda. So the most challenging is the STEMI transfers. What does it mean? So that's the third pathway. So some of you may come from community hospital who are not performing PCIs or you don't have a cath lab. So this is the pathway for you. So within 120 minutes, the moment when your patients arrive in your ED, up to the time that the blockage is, when we reopen the artery, that is the pathway for the STEMI transfer. So within 120 minutes, but if you think of the amount of work that has to happen in between that 120 minutes, the transfer center has to be involved. You call the transferring ambulance, the traffic of New York City, and it's busy. Our partner is Mount Sinai Queens. So from the time the patient walks in the ED of Mount Sinai Queens, up to the time the patient's on the table of the cath lab, and we prepare the patient and we restore the flow. More often than not, it's more than 120 minutes. So, but we try to make sure that within 120 minutes, again, why? Because evidence-based, we have best patient outcomes if we follow these guidelines. So just to review before I go to this, because there are changes in the criteria last year in recognizing STEMI centers. 3 pathways. First medical contact to device, those so-called 911, within 90 minutes, that's the category for that. The walk-in ED, the triage patients on the Mount Sinai Hospital, 90 minutes, and STEMI transfers. So a non-PCI capable referring hospital going to a PCI capable hospital. So for Mount Sinai Queens to Mount Sinai Hospital, it's 120 minutes. So these are the things that we always review day in and day out whenever we have a STEMI case. So why am I discussing this? Because AHA revised, you can see at the bottom, May 2020, the criteria for any hospital to be recognized. So this AHA Mission Lifeline STEMI recognition started in 2010. They have recognized outstanding performances by hospitals who provided best patient care and those who met or exceeded who exceeded the requirement for all their guidelines. So for us, why are we discussing this? And I know they say, oh, we have received Gold Award for the past couple of years, but still we haven't gotten the Gold Plus. We will know the news probably end of June if we have achieved it, hopefully. But working in Mount Sinai Heart, we always want excellence and to sustain excellence. And when you want excellence, there's no end for process improvement. So, so the revised criteria for the mission Lifeline right now is, I'm sorry about that. I would like to add 2 more metrics in addition to the 3 pathways. Door to first EKG. When the patient presents in the triage, within 10 minutes, you should be able to do the EKG of the patient. That's the requirement of, may it be Mount Sinai Queens, may it be Mount Sinai Hospital. It has to be done within 10 minutes. And then if it's a Mount Sinai Queens transfer, within 45 minutes, the patient has to leave the ED. So these are the metrics that we measure every time we have a STEMI case, we review within 24 hours. And I will show you in detail in the next slides. So the changes before is only 75% of cases, they have to meet the criteria and you'll be given the recognition. But you can see here that the door to first EKG, they increased it to 85% or greater. It started, they're just making every rule harder. So it's fine, you want to get better every day. And they continue the achievement score 75% or greater for these variables, which are the walk-in ED to device and the aspirin at discharge, beta blocker at discharge. So all these components, actually, it's tied up to our discharge bundle order set. So any provider discharging patients, they make sure that they check off this. These are all measured, these are all reviewed, and Andrew later will just show the amount of data that we have to do quality-wise because it's important. Why do we need to achieve all this recognition? Aside from making sure that you have the best patient outcomes, it's also, it helps with national ranking. So it's definitely an achievement for any institution, but it helps with national ranking because quality is a major component that they consider whenever they rank a hospital. So before, for the plus, that's including its transfer, before it's only first medical contacted device and walk-in ED that they measure. But now they require, and the transfers metrics is optional. But starting May 2020, they required that you have to meet this criteria for STEMI transfers. So they started with 50% of your transfer patients, they have to meet 120 minutes. And then they added now, what if the patient from Queens, they say the patient lives in Astoria, they called 911 for something else. They said you have severe abdominal pain. And the patient arrives in the ED. They didn't know that it's STEMI. And then they just recognized, oh, it's STEMI. They started counting the time that the patient called 911 to the 120 minutes. So it's very challenging. So it started with just 25% of that you have to meet. So they're adding and adding more of this criteria. It's challenging, but actually it's good because, again, research and evidence-based, that's how we operate in Mount Sinai Heart. So I just want to share with you our journey for the past 3-4 years. And end of 2016, Beth asked me, all right, it's not only door to balloon that the physicians will be measured. Now it's multidisciplinary because Beth is head for AHA, the first nurse president from AHA in New York. So we really take it very seriously, multidisciplinary, all the coordination, all the communication, that this is not only door to balloon, it's now we are joining the mission Lifeline. And I had to talk to, it took me an hour to sit down to figure it out. And I had to set up meetings with FDNY, all the transfer center. But again, the reason why we're presenting 3 here is we cannot achieve any initiative, especially quality initiative. You cannot do it alone. It's always a team. To be able to reach your objectives, you have to work collaboratively as a team. So you can look here, we started with 2018, 2019, the tracking really closely all our data. You can see we're 100% with our ED, with first medical contacted device, and then also with walk-in to device. So it's like, okay, you're 100%. But right now we're averaging 55 minutes for our door to balloon. We can definitely improve on that. Why is it that with the door in, door out and the transfer patients, we require 45 minutes? We want to always up our game. So from 70-something minutes for the past 3-4 years, we now decrease to 55 minutes. It's getting better, but we always want to get better every year. So the next slide is here. So this is one of the focus that will segue to, will explain to you why the STEMI app actually was revolutionized. So if you look at it, we did not meet 75% of the threshold needed for our transfers. There's a lot of moving parts. There are different key players, traffic of New York City, transfer center, new fellows, new residents. So we always meet with the team. Like I said, every monthly meeting, we always review our metrics the following day. And we look at the data, and it actually got better. It was like 30% before that. So, and look at the door to EKG with our Mount Sinai Hospital. It's been improving every year because of all the reviewing of data and working together. We really work very closely with our ED and Mount Sinai Queens team. So it's actually last year I think it's 80%, 85% already. But look at this. This is really what we want to work on. It's the dwell time of patients inside Mount Sinai Queens or other referring hospitals. I know it's very challenging for 45 minutes, but we're working on it. There are a lot of challenges, and we really work with them on how to really improve on it. So just want to quickly brief, like 1 minute here before I give it to Andrew, is the current STEMI process is we have manual workflow. Does it work? Yes, absolutely it works. We have gotten better over the years, but definitely there are areas that we can get better on. We always review it, modify the STEMI pathways as needed, and it's as a team, physicians, transfer centers, nurses, leadership, IT team, we really work with them. And we have a very good relationship with our ED, that we even over-activate because we give them the autonomy. If you feel like it's STEMI, then activate it. But the issue is we have increased false activations. This led to unnecessary healthcare utilization, increase in costs, and increased fatigue with STEMI team and even the patients. So like I said, the STEMI transfers, we're focusing on it, because we were given a comprehensive cardiac certification a couple of years ago, and our process improvement focus for STEMI is the STEMI transfers time. So we are working on the coordination challenges and really improving on the prolonged ED dwell time. We have started the STEMI simulation annually for the past 2 years, and Will discuss this more in detail about his experience of our simulation. And this has really helped with our transfer metrics. But technology has transformed healthcare over the years, and we have this new STEMI app that will revolutionize STEMI care very soon. And I will have Andrew explain it in details, and this is a very interesting part, so everybody listen. Thank you very much.
Thank you, Haydee. Beautifully said. So, like Haydee said, healthcare and mobile apps are revolutionizing the way we treat our patients, particularly in the setting of COVID. We've seen an absolute explosion of telehealth. We've seen even things like Epic are getting more complex, and more features are being added. So our goal is to give our STEMI patients the best possible care. And coming off the experience of a lot of our educational applications, we thought it was natural, why don't we try a clinical application to try to solve one of these pain points? So the aim of STEMI Cath Aid was to develop a secure application to streamline real-time communication and coordination between the STEMI care team members to reduce ischemia time and improve patient outcomes. Particularly this area here is where we're focusing on. So there's 3 pathways that Haydee talked about. We have the FMC from a Central Park collapse. We have the walk-ins, and we have transfers. STEMI Cath Aid is particularly good with transfers. So we have a large number of users involved, and this is partially what makes it such a complex project. This isn't just the cath lab, and it isn't just the cath lab and the ED where the patient's presenting. It includes the transfer center. It includes the full-time employees that are managing all of that data for the registry. So within STEMI Cath Aid, we have referring MD. In this case, it's going to be, for a sample case later on, it's going to be the Mount Sinai Queens Hospital. Accepting MD is going to be the Mount Sinai Queens to Mount Sinai Main Hospital. So if you see referring, that means the emergency room, and if you see accepting, that means the cath lab that's going to take the patient in. We also have plans to involve the cardiac ICU, the heart failure and cardiothoracic teams in case the patient is particularly vulnerable and a potential cardiogenic shock patient. We involve our transfer center and senior care that helps with our inter-hospital transfers. We have RN roles and technician roles to help with the entire process too. So this is one sample case of how a transfer from Mount Sinai Queens to Mount Sinai Hospital Cath Lab will happen through the STEMI app. Now, suspecting a STEMI in the emergency department, they'll go through the usual process of performing the EKG, ideally under 10 minutes, to meet the mission Lifeline criteria, and they're going to click raise alarm. Now, in case there's a lot of patients at once, which isn't too common, of course we can accommodate that as well. So when you click raise alarm, you're asked a couple of key data points. Of course, we were asking for the name and date of birth if we can get this information, but critically, we want the EKG image to send over to the cath lab, and we're looking for the FMC, so the first medical contact time, because it's very difficult to find that data point a couple of days later on. Nobody's going to remember what happened 48 hours later. So here you can see there's some kind of quick ways to enter that data without having to tap too much. You select the location, it auto-populates. In this case, it's west of St. Luke's. Since, of course, we have multiple cath labs in the Mount Sinai Health System, we also have to accommodate for different transfer pathways. So as soon as you click submit from the emergency department, the cath lab attending on call, highlighted in red, is going to receive the EKG, all of that information that was put in. They have the option to start a phone call, a video chat, and of course they can go through the usual route of calling the transfer center and ask to be connected. So in order to accommodate our personal workflow, we asked the transfer center to receive the alarm simultaneously in order to not add any process delays. So in the off chance that it's not a real STEMI, we would rather cancel the ambulance instead of asking them to dispatch a little bit too late. So the transfer center has their own user role where they can add an EMS, at which point everyone's able to click on this button and see on GPS exactly where the ambulance is, when they picked up the patient, if they're close to getting to the cath lab. So they're aware of their location at any point, they can better prepare to receive them. Now, only after clicking confirm by the cath lab attending do the nurse roles and the technicians get activated. So this is implemented to try to reduce false activations. Now, regardless of whether or not it's a real STEMI, if you activate, you're going to have to take that period, you're going to have to pay for that. It's going to end up being wasteful to the health system. So the nurses, they can communicate to better prepare for the patient's arrival. They can add vitals on the right side here. If, for example, the heart rate is abnormally high, the blood pressure is abnormally low, we have a little warning sign here that says this might be a cardiogenic shock patient. So you might have to activate your extra care teams. You got thoracic surgery, heart failure, cardiac ICU, anything you might need in advance, not after the patient arrives. We have a shock screening over here done by the cath lab attending that can activate and then raise another alarm over here so everyone's aware that this patient's particularly vulnerable. Then all members can participate in the chat. They can send each other messages and images, all secure, encrypted, and not over a text message. And then we have medications. So pre-filled, you click aspirin, you'll see the 3 doses that are commonly given to STEMI patients. You can click for status updates over here. And you can see kind of a tracker of key data points. So for example, we see when was the request raised. We can see when was it accepted. How long did it take for the attending to accept that case? In red over here, and on the general patient alarm list, you can see the FMC. So you have a sense of how urgent is the situation. Are we going to meet that metric or not? Then we have some additional points, such as notifying that the cath lab is ready to receive a patient. I think we have 6 rooms generally, so usually we have space, but maybe certain cath labs will have to really struggle to make space to receive that patient. We have pre-procedural metrics and a few other data points. So this is a quick video recording of a sample simulation transfer from Mount Sinai, Queens to the main hospital. What you're seeing is the referring MD is the emergency room physician, accepting IDs the cath lab attending, and the transfer center, just because 3 fit comfortably on the screen. So the referring MD is going to fill in the required data in order to raise a patient. And if you like to look on the lower right, there's a timer to show real time how long this took. So while recording the phones, to get a general idea of how much time does this take. So these little markers, pending review, completed, accepted, there's under review. This gives you a sense and understanding of has the case been reviewed yet? So if you're the emergency room physician, you might become nervous. I'm sending out this message. Is somebody looking at it? So it's going to change to under review, so you can know that the cath lab attending is reviewing the EKG, and you can expect a phone call soon to discuss the status of the patient. So right now the case has been accepted. There's a chat going on to ask a couple of questions. Patient vitals can be added by multiple members, but traditionally I think the nurse is the one that will handle this. We have shock screening. Additional members can join the chat. And then clicking on this little ambulance button, you're able to see GPS tracking, and then just wait for the patient to arrive once all the data has been input. I believe also the chat is where we plan on doing the nurse-to-nurse handoff as a small change to our workflow. Just a couple more seconds. We have some chat. So about 4.5 minutes is how long this video lasts. We have GPS trackings enabled, so all the people involved in the case are able to understand where the patient is, when to expect them. We had a quick chat to understand the status of the patient. We shared vitals. We alerted all the team members only after the cath lab attending confirmed that it was real STEMI to avoid that false activation. And this is not additional, this is replacing that complex system of phone calls, like a daisy chain, from the ED to the transfer center to the cath lab. Then you have to find the attending. So this is going directly to the people that are going to be taking care of this patient. There's a wealth of discharge screens to help collect these metrics from the cath lab side. And then around 80 to 90 data points total, covering about half of the Mission Lifeline registry, can be exported right from the administrative panel. So we don't have to dig around in Epic for too long to find all this information. Within the web portal, the administrator can add new users. They can schedule existing users. They can look at all of the alarms to see the status of multiple patients. They can export data, look at EMS. All those features are available. And then in addition to the administrator, to kind of make the life easier of some of the nurses in the ED, we made, except for the video chat, all of the functions available in a web portal so it can be used in a workstation inside of the ED. So the details of the rationale and the development of the application, we published it in the European Heart Journal's Digital Health. You can see that Dr. Krishnamurthy, I'm sure he was excited to talk about this as a first author, but unfortunately we didn't have the chance. This is a complex and multidisciplinary process. We spent maybe 2 years speaking with Mount Sinai's information security, compliance, Mount Sinai's own ED, Mount Sinai Queens ED. We spoke with all of these groups, many meetings, and it's really coming together into something very impressive, I believe. So what's important, I believe, is that your workflow for STEMI treatment has to fit your needs. And it turns out that sometimes it's best to come up with something custom that can really help out. So let me introduce Wilfred Tan. He's one of the STEMI nurses that's been instrumental in a lot of the development and especially simulation and testing of STEMI cathode at our health system when we were doing it with our own ED and Mount Sinai Queens. Will.
Good afternoon, everyone. I just want to say in advance, please forgive me, I'm a little shy. So a little nervous right now. I feel like this is karaoke. I'm not a good singer, so anyway, good afternoon once again. My name is Wilfred Tan, and I'm a nurse in the Mount Sinai Heart Cath Lab, where I've been working and been part of the STEMI team for about 7 years. The process to better our care for our patients is ongoing, evidence-based, nurse-driven, nurse-driven and standardized, which have shown to improve clinical outcomes. We have also performed many simulations and test runs within the Mount Sinai Health System to continue to improve our STEMI process and identify and rectify any issues that may arise. As a cath lab nurse, we all know communication and coordination is key because time means life when treating a STEMI. Even a minute can make a difference between life and death. Non-uniformity of STEMI management can create confusion, delays in patient care, and increases complications and mortality rates, especially from an outside hospital transfer facility. The simulations and drills we have done have helped increase protocol familiarity, competence, strengthen interdisciplinary as well as interhospital relationships. Goal time for door into device time and door into door out time have been met and continue to improve year after year. Despite these stellar achievements, thanks to the RNs, MDs, NPs, CVTs, transfer centers, CVTs especially, there's always room for improvement, as we all know. The STEMI Cath-Aid app further strengthens the communication between the hospitals and their teams, including EMS and transfer centers. This is because the STEMI app allows for a single communication forum rather than a fragmented communication, which is what exists currently, unfortunately. The current process involves multiple individual points of contact between the referring and accepting team. It can sometimes be frustrating calling the number on the pager, then the attending, then the fellow, then the CCU RN nurse, then the CCU charge nurse, then the CCU fellow, and then also gathering your team together and then finally calling Mount Sinai Queens, trying to get a handoff. So it can get very confusing. Just like this run-on sentence, this process is lengthy and you can run into different issues with miscommunication. The type of communication is suboptimal and time-consuming. Not only do we have fragmented communication, but sometimes we have inappropriate or false activations. These false activations have ramifications that lead to both clinical and financial costs as well as team fatigue. I mean, look at me, I got grays already, I'm 35. Imagine just being activated multiple times. So this is like one of the most concerns that we have. Sometimes we get paged from a stroke team, sometimes from the ER, and it's not even a STEMI. So this streamlines everything and corrects everything. It filters out all the false activations. Another issue that may arise is the estimated time of arrival. Where's the patient? This is the most asked question in the STEMI transfer case. Oftentimes, we have to call the transfer center to provide EMS current location for updates. First medical contact time is another pertinent information that is vital to the STEMI metrics. However, knowledge gap exists as is not currently part of our handoff report. When we say door to balloon, we really mean FMC to reperfusion time. Crucial information can sometimes be lost in translation during these events because these situations can often be hectic depending on how critical the patient status is. The STEMI Cath-Aid app can improve handoff between RNs because it streamlines pertinent information such as medications given, updated vital signs, and overall patient's condition. The chat is open for both accepting and receiving teams, which reduces the telephone game. And if unable to type on a chat, there's a video or audio call feature where the team can give off handoff. And this app can also be accessed through a web portal or any Apple or Android mobile device, which facilitates rapid assessment of the patient. You'll have more hands-on time with the patient having a STEMI. I feel like I'm having a STEMI right now. I'm sorry. Digital handoff, without a doubt, facilitates ease of reports urgency, accountability, as well as strengthens the multidisciplinary team through a better form of communication. The GPS feature provides transparency within the app, as the team is able to see live tracking of current patient location as they are transferred by EMS. Knowing what's going on clinically with the patient and their current location, the accepting RN and CVT can work together, best prepare the procedure room, and anticipate any assistive device, equipment, and or medications needed for the procedure, which will decrease any delays. Just want to show you a photo of one of our simulations with Mount Sinai Queens. You'll see one of our senior nurses there. She's the patient. That's Mary. Shout out to Mary. She's watching right now. So, in summary, the algorithmic approach will improve communication and coordination between teams, facilitating rapid assessment and transfer of STEMI patients, filtering false activations. Live tracking feature provides us the patient's current location and ETA. It promotes a sense of urgency and accountability to meet metrics and improve patients' clinical outcomes. STEMI Cath-Aid promotes early recognition of shock and helps prepare the receiving team for any possible assistive device. This is vital to improving patients' outcome once again. Currently, the app is in its final stages, and the rollout is very soon. So, future directions. We are working on an update for our video conference feature to include the heart team incorporating CCU, CCL, cardiothoracic, and the heart failure team. This feature will keep everyone in the loop. And also planning on expanding to our other emergent and critical time-sensitive conditions such as stroke, aortic dissections, etc. So stay tuned because great things are coming. And thank you, everyone.